I do want to very briefly give an update on the office so everybody's on the same page. I'm sure most of you know that the medical cannabis program is operational now. There are retail sales being made to patients in West Virginia. We have 2 dispensaries open, one in Morgantown and one in Weston. We expect that number to continue to expand quickly throughout the end of this year and early next year. Otherwise, I will turn it over to you. As you probably noticed, we do have a significant number of guests here, and I would suggest that you set ground rules for participation at the beginning of the meeting.
Thanks, Jason, and thanks on the good news that finally there's dispensaries open in West Virginia. I know it's been a long process since this bill was passed. It's been a long process on the board, and I know it's been a lot of hard work for you at the Office of Medical Cannabis, so thanks. As far as the meeting protocols go, the main thrust of the conversation this evening, I believe, is going to be around the home grow proposal that Rusty's put forward. We're going to get into that in a minute, but I just say I'm really thrilled to see how many people from the public are on the meeting. You know, when we started this board initially, we had meetings with very well attended, with lots of people from around the state that would come, and we'd have almost standing room only at some of the meetings. I know with the pandemic, it's been a little difficult with some of these online meetings to get the same type of involvement from the public, and I'm really thrilled to see how many people are participating this evening. So anyone that wants to make a comment or address our subcommittee here is welcome to do so. So you understand, this is a subcommittee of the full Medical Cannabis Advisory Board. We will meet this evening. We'll have some discussions, some presentations, and then ultimately report back to the full board at the next meeting. But what I would ask is anyone from the public that's on the line that wants to comment or wants to speak, there'll be a brief period for that at the end. We will need to limit those comments to about a minute or so, depending on how many people want to talk in order to get through this in the allotted time. We'll get to public comments at the end. So if you can hold your comments until then, we would appreciate it. There is also a chat forum, obviously, in Zoom, and we'll look at that too if there's people that don't want to maybe chime in with their voice or with their camera, so you can do it at that point. Having said all of that, I really think this meeting, given where we were last time and where we've been with the full board, the thrust of this meeting and what we're looking at this evening is Rusty's proposal with respect to home grow. And I understand he has arranged for a couple of speakers that have been sort of instrumental in how that's worked in other states. And what we're always trying to look at for this board is a way for us, if we're going to make recommendations for or against something, can we look at what's been done elsewhere and not have to reinvent the wheel? Because obviously there's a lot of this that's moved forward prior to West Virginia doing this. So everyone understands it's on the line. We are an advisory board. We make recommendations ultimately to the legislature and to the governor's office. We are not legislators ourselves. We don't write the law. We are charged with trying to review what's been written, understand how this is being implemented by the state DHHR, and then we make recommendations about, are there ways that this can be better, both to help the patients and to make sure that this is a viable industry so that it's there for patients. I know it's been a very long time getting this from where this law got passed years ago now to actually having the dispensaries open. Anyone that's been on these prior meetings knows that we've had a lot of discussions about what's going on with the time frame. As most of you probably know, there were serious issues with the initial legislation that needed to be fixed. Those had to be done by the legislature. Our board actually was very active, met a number of times, and we actually got our report about the fixes for the bill out to the legislature and to the governor's office earlier than we were required to or asked to in the initial legislation, because we realized those issues. And then, of course, it took time legislatively to get those through. So having said all of that, I know sort of a long-winded way to get to what we're dealing with tonight, But I think what might make sense is to turn this over at this point to Rusty, because this is sort of his proposal, and to get his initial thoughts on where we're at with the proposal that he wants to make to the full board. And then he could introduce, I think he asked a couple speakers to be here this evening, unless any of the other board members have comments before that. Joe, are you on? I can't see you on there. I assume you are.
Yes, I'm here.
Okay, good. Rusty, take it away.
I appreciate that, Jesse. Thank you all for being here and participating tonight. This is great to see so many people from the public here on this call. This is the kind of input that we need to make sure that we are making the right decisions here. And I was tasked with putting together a presentation, a home-grow presentation for the December 16th meeting of the full board. And there's been some questions that have come up in our previous work group discussions pertaining to this subject around issues of security and potency and things like that. And I've laid out the philosophical argument at least 4 times as to why I believe home grow is crucial for West Virginia. We are one of the most economically depressed states in the country. We have 442,000 West Virginians rely on Medicare for their health insurance. Another 564,000 West Virginians rely on Medicaid. That's 29% of the population, with 87,000 West Virginians that get both Medicare and Medicaid. So when it comes to the financial aspect of all of this, that it's going to be a real barrier as far as patient access goes. As everyone on here probably knows, insurance, because of the federal Schedule I status, does not cover medical cannabis products. So everything that patients are buying at the dispensaries, that's money coming out of their pocket. And a lot of folks here are suffering with some very serious ailments, and extra funds they're not available here in West Virginia like they are in some other states. So when it comes to the security issues and the potency issues, I thought that it would be best to bring in folks who can answer these questions before we put together the presentation for the December 16th meeting. And the first person I'm going to introduce is Lissa Satori. She's one of the leading advocates in the Midwest for the past decade, former employee of Marijuana Policy Project, where she was involved in writing regulations and laws in 2 states, Ohio and Michigan. She served as the Director of Development for the Foundation of Cannabis Unified Standards, which is a health and safety organization, and currently works for the largest cannabis corporation in the nation. Lissa, thanks for joining us tonight. So one of the main questions that we've had come up in these discussions has been surrounding security. We want to make sure that if people are growing their own, that it's out of hands of kids and it's out of public view and all of that. When you guys address this in Michigan, what's the home grow situation look like there?
So that's an excellent question. And I'd just like to start by thanking everyone for allowing me to speak this evening. I've actually done more than drive through your state. Back in 2018, I was brought into the State House by a group within your state that was interested in holding cannabis licenses. And through that experience, I got to meet some of the patients and the citizens of West Virginia that are the true stakeholders in this conversation, and formed some relationships with some people there that make this a personal issue for me as well, even though I don't live in West Virginia. I always like to start these conversations by encouraging every single person listening to at least to be honest with themselves with the fact that the word marijuana or the word cannabis elicits emotions. And it elicits emotions for every single person out there, whether it's a positive emotion because it is something that you use to help alleviate your mother's suffering in her last days with cancer, whether it is fear or trepidation because you had a family member that experienced addiction and they began, their experimentation with cannabis. I encourage everyone when we start talking about laws and regulations that are meant to help those that are the most vulnerable among us, that we try and start to look at cannabis taking the emotion out of the conversation and look at actual results, actual pragmatic approaches, and view it as a way to provide access to the sick, not just to put into effect what I call legalized prohibition, which are programs that are so restrictive, all they do is simply push the patients out into the surrounding states that have less restrictive programs. That little intro being said, the Michigan program was interesting and different from other states because in the whole nation, we've always had to kind of meet the states, where they are, and also meet the federal wave of regulation where it is. At the time that Michigan was originally had its first law passed, that was back in 2008. And it will almost sound backwards to you because industry was not legalized at that time. The very first right that was given to the citizens and the sick people in Michigan was the right to grow their own cannabis, and the right for caregivers to be able to grow cannabis for the patients as well. Now, 2008 was a completely different time politically in all states, and certainly a completely different world in the arena of cannabis legalization. At this point as a country, we've moved in general past the conversation of individual states legalizing. It's taken as a given. And the same people, such as Marijuana Policy Project, that have worked on these state laws that exist now, are the same folks that are at the forefront of the federal laws that are coming down the pike. So when you look at building on other states' programs, which I highly encourage everyone to do, there's no reason to reinvent the wheel when the information and the programs are out there and you can see the results of them. You have to keep in mind that policies and laws that were passed later in the process of legalizing the country are building on the mistakes of the earlier states. And also, we are all still learning as we move along. In Michigan, when the regulated industry was brought in and the state took on the laws that govern that portion, everything was relooked at. And the way that home grow stands in the state of Michigan now is we have caregivers. Those caregivers are able to grow 12 plants per patient, plus 12 for themselves. They are able to supply those caregivers with the plants out of their garden or products made from those plants out of their garden, and without remuneration. So they are not selling the products to caregivers. They are gifting this cannabis to sick people to help them gain health. With that, we also put in the law certain things that enabled for safety that you'll find across the nation in any of the laws that include home grow. Language that states that it must be out of public view from any public spaces. And so when you go through Michigan, you really won't even be able to tell that anyone is growing cannabis at their residence or have home grows. We are able to grow outdoors as well as indoors in the state of Michigan, which I highly recommend for a variety of reasons that I can go into if anyone has any questions on that. And what we've seen is a bit of a boom in industry in ancillary businesses that supply these home gardeners with products as well as build small greenhouses. You can easily keep things out of public view and locked with a variety of ways. We did not dictate that in the law in Michigan because putting constraints on individual homeowners that have very different properties and layouts, abilities. Some people have children, which definitely dictates where a garden would be able to be located in your home, those types of things. We want to give people the freedom to safely cultivate in whatever way works within their individual situations. And the main thing is that it's locked up. So the language can be very general, but still cover all of the bases, where anything that is growing must be kept separate. Anyone who is not a patient, it does not have access to the plants. And that is pretty effective. When we hear about things that go wrong, I'm not one of those free the weed people that doesn't think that, it should be unregulated or that there aren't issues. What I do understand from experience and watching how it's played out is that those issues are minimal compared to the fears that a lot of folks have. And so when you're thinking about safety when it comes to children and those types of things, I encourage you to think about this medicine in the same way that you think about prescription drugs, most of which are much more harmful to be ingested or overdosed on than any form of cannabis that a child would accidentally have access to. It all boils down to education and parenting, of course. And I'm a mother. I'm a mother first. Half of the campaign team in the state of Michigan that brought adult use to the state are mothers. And child safety is a huge concern of ours. We encourage folks to be responsible parents with everything, with guns, with prescription medication, with things and foods that a child may be allergic to. Again, when you take the emotion out of the conversation, this becomes a very pragmatic thing where we discuss how rather than if we keep people safe. We've also in the state of Michigan had some of the tax dollars allocated to counties specifically, who have given that money to whether it be law enforcement, local health departments mostly. And those health departments have utilized that money to run educational programs, provide free lock boxes for patients that happen to be parents in order to be able to keep their cannabis locked up. And those are just extra things that we don't do for pharmaceuticals that, maybe we should. But the point of this all is that we don't see market problems. I know that one concern is anyone who can grow cannabis at home then would be tempted to become a illegal cannabis dealer. And to be as candid as possible, the folks that are interested in doing that in your state are already doing so. The folks that are willing to break the law in order to grow and sell cannabis don't care if you give them a 6 plant count, a 12 plant count, or a 40 plant count. They are folks that are willing to operate outside of the law. A home grow provision in a state does not increase that. It does not encourage criminality. What it does is it allows an avenue for people to actually have medicine that works. You can give people access through a dispensary, and I am almost done. And those folks are still not necessarily going to have access to cannabis that works for them. Here in Michigan, we are widely known throughout the country as the most accessible state and also one of the states with the least expensive cannabis in our shops. Even with that, 1 month's supply of RSO for a cancer patient costs $1,500 out of pocket for 1 month. Here in the state that I live in, the truly ill and dying people that need the medicine the most, they don't purchase from the shops for the most part because they need things that are not that profitable for the licensed companies to produce. The caregivers and the folks growing at home are the ones figuring out what medicines, what strains, what delivery methods works for the people in their network that they care about, and producing those because they are not producing for profit like the companies are. And even in Michigan, it is difficult to find RSO in the shops. It is difficult to find true medicine in the shops because it's not produced at a rate and it's not the type of plants that can be grown for maximum profit. To kind of wrap this up for you, the most vulnerable And the folks that are most affected by lack of home grow and lack of product variety in a state are truly children, and they are truly those with the least amount of resources. From someone who doesn't live in West Virginia, it breaks my heart when I think about how your state has been exploited by those of us who do not live there, and the amount and the number of heartbreaking situations that have even come to me since 2018 when I first stepped in the state on this issue. The first person that I helped illegally obtain cannabis in your state is an elected official in your state. His wife has cancer. He was scared to death, and he spends as much time in the state house as anyone on this call does. Some of you probably know him. He would never tell you that he is pro-cannabis publicly. It changes things when you start to look around and you understand that your colleagues, some of them are criminals right now because they love someone who is sick. In closing, I'd like to offer, I don't think that my colleague Robin was able to make it tonight. Robin Schneider is the former executive director of the National Patients' Rights Association. She also served with me on the campaign team in Michigan. She works directly with the regulatory body in Michigan, the leader of which, Andrew Brisboe, was just appointed as the president of the National Cannabis Regulators Association for the whole nation. We are very much utilized as an example for upcoming and oncoming states. Robin currently leads the Michigan Cannabis Industry Association, where she represents licensed businesses in our state. She's asked me to offer her support and offer herself, the association, the lobbyists, our lawmakers, our regulatory officials here as a resource to anyone on this phone call that would like additional information or has additional questions about Michigan and how we made it work up here for both the sick people as well as the regulators, as well as those who are licensed companies. Thank you very much.
Thank you, Lissa. I truly appreciate you being here. I truly appreciate Robin's willingness to step in and help us out as we travel down this path as well. So that is, I can't thank you enough for being here. You touched on something in your remarks when you're talking about even with the dispensaries open, patients still don't have access. And there's a patient on this call that I really think you guys need to hear from. Becky Nicholson is a caregiver and a patient advocate and a wife of a veteran who relies on this medicine. And Becky, if you wouldn't mind, I would just kind of like you to share with the group and share with everybody what your experience has been as a caretaker living in West Virginia.
Absolutely. Thank you so much for having me, and thank you for that introduction. Thank you to the board for listening. So I am very familiar with cannabis, as my husband is a veteran. He was a combat veteran in Iraq, and he as well suffered with PTSD and anxiety coming back. He relied on the VA with the regular meds, the traditional meds that we use, the psychotics, a lot of antidepressants, a lot of counseling, and just didn't get anywhere for him. So many years have passed. He then was not successful with the VA treatment programs. We had him in a couple different programs there, and then he was then willing to try to go outside of the government. So we spent time and sent him to a place in the state of Washington, Center for Hope. They did a fantastic job with helping him. They got him on some non-traditional meds, some Western civilization medications that once he came back here about 5 weeks later, they weren't available to us, one of them being cannabis. Out there, they were using CBD oils and tinctures and compounds. He did last maybe about 2-3 weeks once we got back home and those meds were no longer available. He then slowly started to dissipate. It ended up with us having to call the state police for help. They came to our home and did a mental health hygiene, had him removed from our home. And he was then placed in a mental health facility at that time. He was put on more psych meds, released to an unknown person, I found out he was discharged. I went and picked him up. He was living with someone in a trailer who had no electricity, who was a drug addict. And this is where our psych facility decided to let my husband go, that they felt was safe for him at that time. Relocated him, got him back home, and put him into a hotel until I could get him into a treatment facility because the VA had nowhere for us to go. Came to an organization called Helping Heroes that was able to facilitate getting him back into that community, that brotherhood, that socialization that he missed from the military. They started doing more treatment with him. And then we started going back to what meds worked for him, which was the non-traditional meds that the VA won't pay for. Being in the state of West Virginia, it wasn't possible for us to be able to have that happen. He was successful. He completed the treatment program and then later needed to move because he couldn't stay on the medication that worked best for him. So my husband relocated to Washington, Pennsylvania, because there he was allowed to go ahead and participate in medical cannabis. Since he started that program, it has been phenomenal. He's no longer had to be reinstitutionalized. We've not had any more episodes to where he's had to rely back on the system or be institutionalized, and it's changed his whole world. This is someone who was a state trooper for 11 years, who fought for our freedom. And I know there's this stereotype that goes with cannabis that makes you feel like they're doing something wrong. It's a criminal. It's someone that's not a member of society who's productive. And that's why I wanted to talk to this board and let you know that these are just like other people have said, these are your coworkers. These are people that are next door that are already using cannabis. And so we're only hurting those that don't have access to it. The people that are illegal already getting access to this. So instead of punishing those who have fought for your freedom, which is 10% of West Virginia, 10% of our state are veterans who suffer from PTSD. 22 veterans a day die because of suicide and lack of medication and help. So I'm asking you to allow homegrown because it's not affordable. I've already been through this. He's in the state of Pennsylvania. He lives on a nice budget of $3,000 a month, which is more than most West Virginians have to spend. And still, he's not able to keep up with his meds. Many times he does without, even being frugal. He can spend anywhere from $500 to $1,500 on medication a month that's not covered through the VA because it's illegal. I can't afford that. I work a full-time job and a part-time job as it is. I do the best I can, but he shouldn't have to go without meds. There's a therapeutic benefit to being able to grow your own product. The VA has had a horticulture program for over 7 years now that has been quite productive. It's not only helped them medically, it's helped them health-wise and mentally. It's a homeopathic option that is very cost-effective, but also allows treatment. Plants don't cause stress, they take our stress. And it allows the veteran to see what they can be productive at. It allows them to see something that can come to fruition, to start a little seed, and to be able to provide for themselves again. Gives them such a boost in self-esteem that no medication could ever give him. And I need you to look at that and know that that needs to be a possibility, that he doesn't deserve to go to jail because we want to incorporate one more thing in our garden or one more thing that he can have control over. Instead of worrying about how we're going to pay the bills this month, if he decides to get the meds that he needs, because maybe our government's in more chaos, or maybe there's things going on in the news that stresses him out more, but he won't medicate because he's worried about the financial budget. And as of now, the state of West Virginia, we've legalized this, but yet it's still not cost effective. Our dispensaries are open now. I put in an order. I'm 2 hours and 45 minutes away from the dispensary. I verified before I left. I called, got a call center and was told, yes, ma'am, go ahead and proceed. Your order's here. I get there and I'm told, I'm so sorry, ma'am, talk to the manager. I don't have your medicine, and we haven't had your medicine since the store even opened. And I apologize, but it could be several months yet before we can get anything more. It's not an acceptable result. If my husband decided to say that on the battlefield, I don't feel like working today. I don't feel well today. I'm sorry I came up short for you today. Wouldn't be acceptable to us if we lost a family member or a loved one. So I'm asking you to not let this be acceptable. This isn't recreational. This is a medication. It should be available and it should be convenient, and it should allow all the properties that it was intended to for all the patients that deserve the benefit of using it. I thank you for your time and I thank you for listening. Thank you.
Well, thank you for taking the time to share your story. I know from personal experience how difficult it can be, especially in a public forum, to share these personal stories. And I truly thank you for participating in this discussion. One of the issues, and I'm hoping that maybe Alyssa could speak to this, one of the other issues that has been brought up when we talk about home grow, some folks on the board are worried about law enforcement potentially losing money, federal dollars, because of our laws. I have looked and looked and looked. I've been researching this now since we started this conversation at the beginning of the year, and I personally have not found one instance of any police department in the country that has missed out on any kind of federal dollars because of the medical cannabis program. But again, I'm just a patient advocate. I am not from the regulatory side of things. And I was wondering if you could maybe speak to that. Are you aware of any issues that our local law enforcement agencies could run into if we allow patients to grow their own?
So law enforcement, they're people too. And each person that you talk to that's involved in law enforcement will have a different opinion. What I can say is I am personally not aware of any loss of federal funding due to a cannabis program anywhere in the country either. And due to my past work and experience, I feel like I probably would have heard that. What I do hear a whole lot about is local municipalities that get tax dollars being able to allocate that to law enforcement in order to provide forces that do not have resources, additional resources to fight real crime. I have heard anecdotal thank yous, a lot of thank yous from law enforcement officers who recognize me from my work and thank me for allowing them not to have to spend their time on petty things, because that's what they really look at it. Once a state becomes legal and those who have trepidation realize that the sky does not fall and their communities are still their communities and their neighbors are no longer targeted for this particular issue, what we've seen is more of building trust with law enforcement between the community and law enforcement. Monies that go to law enforcement either in the state law and regulations, which is also another use of tax dollars, which is extremely common. Marijuana Policy Project does not introduce a law without allocating money to law enforcement typically, because it is one of the ways that it makes people more comfortable and allows them the resources to deal with the transition. We don't deal with a lot of targeting of patients or caregivers from law enforcement in Michigan at all. My most recent interaction with law enforcement and cannabis was actually with hemp, which is not required to be under lock and key in the state. And a sheriff's deputy came out to take a report of larceny because people had come and ripped those plants out of the ground in the middle of the night. It, for us, truly has been a blessing to free up those law enforcement resources to go after rapists and murderers and deal with the crime that affects us in our communities. And I would be more than happy to provide, again, resources, law enforcement officials to speak to. And our Attorney General here in the state of Michigan, our top law enforcement officer, is probably one of the most educated in the entire state or in the entire nation on the issue, works directly with the cannabis community and the cannabis caucus. And the biggest thing is keeping those lines of communication open and working together.
Great, thank you. One of the other issues that has come up a couple times while we're talking about home grow is the potency of the flowers, the potency of the plant that patients will be growing. And I would like if Dr. Girdman would speak to this. Dr. Girdman earned a PhD in pharmacology back in 2001 from Vanderbilt with a special focus in cannabis and cannabinoids. For over 15 years, he's conducted biomedical research with cannabinoids and funding from the National Institute on Drug Abuse and the National Science Foundation. He's been a college professor of biology, a chief scientific officer for multiple cannabis companies, including starting one here in West Virginia. Dr. Girdman is now, he recently relocated to Nashville, where he is a co-founder and CEO of a startup commodity marketplace for industrial hemp. And I truly can't think of anybody in the cannabis industry anywhere in the country that could speak to this issue from a more educated place than Dr. Girdman. So I would really, if you'd be willing to just talk about potency, as far as what patients are going to be seeing, that would be great. Is that something you could speak to?
I can. Let me ask for a little more guidance. This is specifically regarding home grow. Is it a concern around 10% as a THC maximum, or
well, this work group discussion was primarily focused on home grow, though there has been a recommendation posed to the board about putting a 10% THC cap on all products. So, if you would, although, like I say, the main focus of this work group discussion on home grow, but there have been questions with potency. And if you can just talk about the efficacy of cannabis and the potency issue, if you like.
Sure. And thank you, Rusty. Thank you, Mr. Frame, Mr. Forbes. This is a good introduction to this meeting. I'm well aware of all the work that you all have been doing in getting this program going. And I genuinely have a great care for the West Virginia program taking off. And I think being overly restrictive on things like potency is a way to simply make the program fail and not get adopted, and see stakeholders like licensed companies not put the investment into building out a program in this state. Whereas I also think that West Virginia, and this comes from a great deal of study and spending over 18 months living there until very recently, I think West Virginia has opportunity to have a very innovative program that I think, including home grow, would be to the benefit of West Virginians. It would help it would not be something that crushes the industry. I've been in the industry. I do not at present have any profit or financial interest in any medical cannabis company anywhere. And I don't think that allowing home grow will cripple an industry's ability to succeed. As said many times in many places, lots of people eat tomatoes and relatively few actually grow them. And the comparison is quite valid, because cannabis can be grown at home with due attention and care, but it also can go bad and in the same way that tomatoes can. Regarding potency, I have submitted a great deal to this committee and the board in the past, and I won't take up everyone's time to recount it tonight. I'm definitely not going to recant it tonight. Where there has been discussion about potency, sometimes discussion involves creating a maximum cap around 10%. I have explained and am happy to be at your disposal to discuss why that is an arbitrary value, and it moreover is under what is mostly available in commercial cannabis grown properly these days. As far as home grow is concerned, I tend to agree with what Ms. Satori was saying, that a lot of the home grow efforts will be the truly medicinal focused, patient focused groups that I tend to think that the potency of flowers grown at home, and this isn't just from the top of my head, it's from lots of exposure and experience over the years. I think it's unlikely that percentages of THC potency grown at home are going to be on the high side of what is readily found in the black market or in medical cannabis dispensaries. But what is important, I think maybe the most germane to what Rusty's asking me to speak about, is that THC is the integral part of cannabis as medicine. I mean, I'm a huge proponent and involved in CBD and other cannabinoids. I think medicine is more than just these molecules, but THC is a vital part of the medicine. And while I believe that in the majority of cases, lowered amounts of THC is what is called for, it's what's therapeutic. For a great many people, high doses of THC, a high number of milligrams of THC daily is important, either because they've got tolerance, or because in the case of serious, severe neurological diseases, or in taking a face-on, head-on approach to cancer using cannabis as a therapeutic, high-dose cannabinoids are where there seems to be the most clinical success. And I will sometimes get pushback from saying clinical success because there is a lack of well-controlled clinical trials, so showing that cannabis is effective in fighting cancer in human populations. But there are an enormous number of human beings who have become cancer survivors by taking an approach, and Mr. Williams is one of them, by taking an approach fighting cancer using cannabis, and it is consistent with a great deal of preclinical research, including work with animals, but also with humans, that high dose THC cannabis is the most most likely to be therapeutic. And as I say, there's a lot of survivors that have gotten through cancer using high dose cannabis, a great deal of THC as part of their strategy. So there's biology to back this up, and it's what I've directed my whole professional living towards, and I've lectured to and educated physicians about this for years, both medical students within university medical programs and physicians through continuing medical education programs that are accredited through distinguished universities. So my background there is clear. Yeah, so I know that you're aware that there is no percent or dosage of THC that creates a fatal outcome in patients. And that really simply can't be overstated how completely different that is from almost every single thing that you will find on a pharmacy shelf. Cannabis is an herbal medicine. I am a big believer that the engagement with cultivating the plant adds to the therapeutic value in many situations. And even if there's a situation where there's a caregiver growing, having a connection to the plant for people that are choosing a natural, holistic approach to their healthcare through cannabis, I very much believe, and have many physicians supported this interpretation over the years, that it adds to the holistic therapeutic value of the medicine. And I think that's a really valuable service that can be done in that state, especially, as Rusty has said far better than I would, that the economics of what it costs to buy cannabis in dispensaries is going to be out of reach for many of the people who need it the most in West Virginia. That's just cut and dry. It's very clear that that's going to be the case, and home grow can make it more affordable. And as far as the notion of high potency, I mean, honestly, I think that that cannabis users, people that are consumers that are growing it at home, they more likely also will be able to grow varietals that may have lower THC but balanced with CBD. This is another exciting area of science where I'm a huge proponent within the legal markets that I've been involved in, even when I was in West Virginia interacting with licensed growers that just won licenses. When I was trying to line up what would go into my dispensary, I wanted to push to have varieties of cannabis that are balanced in THC and CBD and don't necessarily have high THC concentrations compared to what are market leaders. And again, that's because THC is a medicine, and it's helpful to have high THC cannabis. But I saw that in Florida too. Growing varietals that are balanced in THC and CBD are not likely to be market winners. And so patients have more of an opportunity to do that in a home grow format. And that's part of what I think adds great value. So maybe I'll let you ask if there's another question, Rusty. I don't want to occupy the time sort of pontificating about this.
Well, I appreciate your comments. One of the things that Lissa touched on earlier, and you also touched on in your remarks, when we're talking about the cost of this medicine, when you walk into a dispensary, and from the dispensaries at least that are open now in West Virginia, for 1 gram of a concentrated product, you're spending about $70 a gram. For a cancer patient who is using cannabis oil or Rick Simpson oil, to try to shrink tumors or to get through chemotherapy, you typically use about 1 gram a day. That puts this completely out of reach for folks if they would have, even if Rick Simpson oil, if it were available at the dispensaries, which it's typically not, because it's like you said, it's not, it's just not a priority. It's not a high seller, so they don't really mess with it. But where if I could grow my own and produce my own oil for that same $70, I could produce enough Rick Simpson oil to last me for months and months. So as far as just the cost benefits that this would be for patients, to me, that's something that, we have got to take into account. Again, I can't stress it enough. I've said it every time that we talk about home grow. We want businesses to thrive in West Virginia. We want the dispensaries to be open. We want this program to be running at full steam. But you cannot disregard the fact that we are one of the most economically depressed states in the country. This is going to be, if every one of these dispensaries were up and firing right now, I still know more patients than I could possibly count that can't go and buy their medicine. I spoke with a few patients. I was up in Morgantown for the opening of the True Leaf dispensary, and there were patients in line that were crying because they were happy to see it there. They were happy to see this program open. They have their cards, but they weren't even going to bother walking in because they could not afford product. And, to me, home grow is the best way to facilitate patient access and to do it safely. One of the things that I hear, and with some of the comments that have even been made with the advisory board, it's almost like some folks are looking at this issue, and Alyssa touched on this earlier, like medical cannabis patients, like they're doing something wrong, right? Like this is a crime, and we've got to remove that mentality from this conversation. They're not criminals. They're patients. They're sick and they're in need of therapy. They're in need of help. And it's, in my view, the role of this board is to do everything we possibly can to facilitate the best patient access. And I just don't see how it's possible without home grow. There has been some talk about people are hesitant to support home grow because the dispensaries are not up and running yet, and they think that this is going to take away, from dispensary profits. And from my experience talking with patients in other states, it's just not the case. We live in an instant gratification society. Most people, if you give them the option of, spending 3 to 4 months painstakingly taking care of some plants just to hopefully get enough of a yield to medicate, or just drive to the dispensary and buy what they need, most people are going to go to the dispensary and they're going to buy what they need. It's my opinion that the only people that are really going to grow are the folks that absolutely have to because of the financial barriers, or your hobbyists. You're always going to have those. But, as someone who has worked in this issue in multiple states, when you see home grow, how is that an issue? Does it really affect dispensary profits so much so that we should be hesitant to do this here?
I don't think that's a serious issue at all. And I also, concur in many ways about how patients that are going to be growing their own are going to put you put care into the medicine from the entire life cycle of the plant. It takes much more effort, and I think that patients will be very thoughtful and attentive to what they're doing. Now, that said, you will legislators, if this goes forward, will need to deal with issues related to, for example, what Lissa was referring to about remuneration. I mean, one will need to guard against the cottage industry of growers who are going to be growing and selling cannabis anyway, just creating that and trying to use a shelter of the program. But as far as impacting the state, look, I mean, I've been inside the West Virginia cannabis program. I've looked at pro formas and business models, not only for my own the company that I was involved in, and I'm completely divested from. But there's, even with the issue that most patients can't afford it, the West Virginia dispensaries are going to be, in my prediction, there's going to be more demand than supply for a while, in part because companies have seen the pace of rollout and concern over certain issues about what products may or may not be available, and the fact that physicians have been, in my view, in that state, chilled in different ways for participating, and so there's a slow rollout of patient numbers. That has been factored into the amount of canopy space that growers are growing. So they're not. I don't think that and this is based in other states too. It's, if there is a surplus and a trouble selling product, then what they will do is mark down product, and then it will become more available and start to compete with home grow. But companies have bought into West Virginia. Yes, many of them. It's certainly, Mark Company started to try and create a value for West Virginia patients. But companies are also going to be creative and try to create a distinctive West Virginia cannabis product, and look towards down the line when there's national legalization and the whole business model is different, and none of that focuses on the most needy patients. If you really want to look, in my view, I agree with you that if the advisory board wants to take most seriously the charge to think about what would improve safe access that will be with cannabis that will be cultivated with the highest amount of care, then home grow is a way to advance that in the most serious way. And I don't think it's going to cripple the industry. Putting like a 10% THC cap, that's gonna ruin the industry. I mean, the companies would simply sit on these licenses like real estate until there's national legalization. Nobody's going to be growing cannabis under 10% and making a living off of it in the state of West Virginia. Home grow, I don't think home grow is going to cripple the industry, especially if you even were innovative and allowed the industry to sell clones and starts to the industry. I mean, to the patient base.
Also, another one of the questions regarding the regulatory side of things. I've been
Hey, Rusty. Hey, before you jump off that, can I ask Dr. Goodman a question?
Absolutely.
Thanks. Sometimes I think if we don't jump into a couple questions, we'll kind of get lost before we get there. Doctor, could you maybe you were touching on the illegal market and THC content. Do you have any information on what THC content on average the black market cannabis has?
Right now, I mean, most of that is skewed towards the West Coast, but a great deal of West Coast cannabis is coming all over the country. But, this is from the hip. but I believe that the average THC potency these days coming off of the black market is going to be around the 12 or 13% THC level. Now, something that's important to recognize is that, and part of why it's folly to base the guidelines on percent concentration is because this changes on a matter of how much you dry down the plant. I mean, you can cultivate it and get it to the right moisture level that enables, that is desirable for you know, I don't know where you guys stand on smoking right now, but whether it's smoking or vaporizing or simply quality product, there's a certain moisture level that's desirable for a quality of the cannabis. And if you overly dry it, well, guess what? Your percent concentration has gone up, and it's the exact same product. It's the same as far as milligrams of THC, which is what matters for what target, hitting your target dose or over consuming.
Okay. Another question I had from something you said, or maybe this is just more along the lines of what comes into my mind every time we bring this up. With respect to home grow across the country, do you see other states enacting that initially as their industry is getting off the ground, or is that something that tends to come later? I guess one concern I've had, both addressing this home grow issue, addressing the potency issue, and some other things that have come up is that we just now in the last, like 2 weeks or whatever it's been, have dispensaries open in this state, and we've only got a couple of them. And one concern I have is making sure, we don't start throwing out recommendations to the legislature that rocks that boat in some way before we really see how the industry is able to handle what's happening and to get it viable and off the ground so we can help patients, even understanding that we are unfortunately a very poor state and people have problems with that. In your experience across the country, do you have any information on what other states have done in that regard, whether the home grow is something that's come with the initial law when it's passed, or it's something that they've added later?
Well, I think that Lissa could probably speak to that better. I mean, most states have not passed home grow. I'm most familiar with Maine, which brought in a home grow provision right early on. And one of my very best friends is a physician there who's worked with thousands of patients and is a huge advocate for home grow, Dr. Dustin Sulak. I tend to think that home grow, I don't know of instances where it's come on later. And I don't know if Ms. Satori is still listening, if she could chime in.
Sure. Yeah, there are outliers on this, sir, but typically when home grow is going to be a portion of the program, it is implemented immediately when the law goes into effect, in part because we understand how long it takes an emerging market not only to get up and operational, but also to stabilize. To think of it as we need to get the licensed industry up and running and get that evened out to see where it falls, to see if home grow fits into that model, is actually the exact opposite way that we talk about it when we're sitting at the regulation tables and drafting up regulations and laws. In part, for industry and for the success of the program. We mentioned patient count earlier, and I can tell you definitively from all of the conversations that I've been involved in and what I call behind the curtain, not with the company I work for, but with other large MSOs and major players and decision makers, that patient count absolutely dictates not only cannabis space, but the day that they start operating, how much investment money they're going to put into their build outs, all of which contribute to the slow rollout, slow access, slow getting that red number turned into a black profit number for the licensed companies. If you implement home grow immediately before the shops even open at the beginning of the program, those patients that are growing at home are still required to register as patients. So every single one of those folks becomes another number on that patient count, which increases the desirability of actually conducting business in the state. When Greg talks about program killers, it is absolutely not an overstatement. What we see with extremely restrictive programs is they either languish, I think I put this in the chat, they languish until the program is opened up to the point where the businesses can be profitable, or they just plain don't get that investment money at all. We've seen licenses in Ohio that have been yanked back because folks didn't move fast enough in a restrictive program. Just last month, Ohio completely changed their caps as far as allotments for the month. New York just started selling flour, although flour was not allowed, and that occurred this month as well. So what we see as a general trend with home grow is that it's implemented on the front end for a variety of reasons. And what we see as a trend with restrictive programs is they are opening up as time goes on, a lot of times because of industry pressure.
Ms. Satori, can I ask you, so in Michigan, it was my understanding they had a medical cannabis program in place before they enacted home grow with the recreational. Am I off on that, or is that?
So very quickly, to kind of give you a timeline, in 2008, the medical program was passed by Marijuana Policy Project, and it only legalized caregivers and patients growing their own at home. In 2016, after years of disproportionate enforcement and some localities actually allowing shops to exist, although they were not technically legal at the time, the state stepped in, passed the medical marijuana law, the second one, which actually regulated the licensed industry. It gets confusing because the timeline of the adult use campaign and law passage overlapped a lot of the implementation of the medical regulations and law, because that law passed in 2018. And so home grow was the first thing legal in 2008. In 2016, the medical licenses were regulated. And in 2019, the adult use program went live.
Okay. All right. I think I understand the track of that better now. All right. Thank you for your comments. Rusty, I didn't mean to kind of jump in and interrupt, but I think, if I or any other board members have any questions, I mean, this is just an open discussion in my view, and it's your presentation as to why you're advocating for this and why you're asking ultimately for us to consider it and then for the full board to consider it. And I understand it's your presentation on that regard, but I just wanted to jump in and ask a couple of questions. So if any other board members have questions, I think that's helpful too.
I do have a question, Jesse. I think it would be good, if the office would actually do a study on, what states allow home grow, when they allow home grow, so that we could kind of see what the national track record is, based on, something that actually comes from our state office. And, that would be a request that I have, because I'd like to have the data right in front of me to be able to see exactly, and, what states rolled it out when, and that would just be a request.
Jason, do you want to address that? Is that something
Sure.
you have information on or can do? And it might also be helpful to understand if there's any current position from the office on this.
Yeah, so as far as the research goes, that would be an easy one. We can get that together real quick for you guys. As far as position, as I've stated before, OMC is going to remain neutral on this issue. I do have regulatory concerns, but I also completely understand that Rusty's point is valid. We get calls every day, and had them today, patients asking if Medicare or Medicaid is going to cover the cost of this, and the answer is no. So it is absolutely a valid concern that we don't have a great answer to.
Okay.
Regulatory.
Get some research for us on that and maybe get that around to the subcommittee. That'd be great.
Yeah, no problem.
Thanks.
As far as the regulatory side of things, I'm curious if you're aware of what they do in New Mexico. When we were pushing, I've been pushing home grow, trying to push it through the state legislature since the inception of the conversation. And, last year was Senate Bill 231. The Senate passed that bill allowing patients to grow 12 mature and 12 premature plants. It passed the Senate 29-5, and then it got over to the House and it died. And there were a lot of concerns in the House about regulatory, how are they going to, basically we're hearing folks that are looking at this like, we're going to allow a patient to grow a handful of plants and they're going to turn themselves into the next, West Virginia Scarface, which is not at all the case. Lissa touched on it earlier and Dr. Gerdman as well. Patients that are growing this medicine, they're growing it because they need it. They're not growing this medicine because they want to go out on the street and sell it. The folks that want to sell cannabis are already doing it. But when I was working on the presentation, for the meeting on the 16th, I was really intrigued with what they did in New Mexico. And they basically set up similar to what we were pushing through the legislature here. We were calling them compassion certificates. But in New Mexico, patients that have to cultivate or that are allowed to cultivate have to fill out this form. They have to register with, with their Department of Health and Human Resources. And there's a $30 a year fee. Once the patient's registered, that registry is available kind of like the way we do with our hemp industry. It's open for inspection. So, basically the DHHR, they know who's growing or who is supposed to be growing. And at any time with 24 to 48 hours notice, they can say, hey, we're going to come in and we're going to inspect your grow to make sure that plants are locked up, to make sure that they're out of public view and out of the way where folks 21 and under can access it. And that was something that at least the Senate was really receptive to. And I'm just kind of curious, especially with the other board members and, with Lissa, where you've worked on the regulatory side of things, is that a sufficient way to regulate, home grow? What are your thoughts on that?
And I'm sorry, my audio messed up there a bit, Rudy or Rusty. I think your question was, how did we regulate in Michigan to address the safety concerns? Or a great bit of what you said cut out, I'm sorry.
Well, I was really talking about what they did in New Mexico with, with patients when they have to register with their DHHR, and it's similar to our hemp laws here. Once you're on that registry, you're subject to inspections just kind of the same way that hemp farmers are, although from the hemp farmers I've talked to, it hasn't been that much of an issue, but it's just one layer of safety, so if they thought something was out of the ordinary or whatever, they could come in and make sure that everything's on the level. I was just wondering from a regulatory standpoint, is that a sufficient way of doing it? Because we do want to make sure, I want patients to grow their own. It's never been a secret. I've been pushing for this from day one, but I want it done safely. We want to make sure that kids aren't going to be able to access medical cannabis, just go out and get the plants and do what they want. We want to make sure it's done safely. So would something like that, a registry and language in our bill requiring folks who are cultivating, if there's anyone 21 or under in the household, the plant should be kept behind lock and key. I don't think that language needs to be too specific, because that could be a spare bedroom, that could be a closet, that could be a small greenhouse in the backyard, as long as it's behind lock and key with that registry. From someone who's worked on the regulatory side of things, I'm just curious to hear your thoughts on that, as far as keeping things safe here in West Virginia.
Well, I understand that in West Virginia, there is not the ability for citizens ballot initiatives. So they really count on their elected officials to be their voice, and they don't have as much power as in other states. What I can say on that issue, Rusty, is it is one of the main sticking points for people who grow in their home. We have a right to privacy. Patients have a right to privacy. And with the extremely minimal issues that come along with regulated home grow, patient registry, suggesting what basically is the equivalent of a warrantless search. When it has been suggested in other states, it has been a PR nightmare for those who suggest it. And it has gotten a lot of public outcry, in my opinion, for good reason. I have absolute sympathy and a ton of experience dealing with folks that would prefer that cannabis does not exist on this planet, even in the face of the proof of how many lives it improves. That being said, it is not needed to be treated like plutonium. I would again encourage you to think about it like prescription medication, like weapons, which are very popular in West Virginia. Compare the statistics in legal states of children being admitted into hospitals because they got a hold of cannabis edibles versus children being admitted into hospitals because they got a hold of pills and other types of access to dangerous thing issues for kids. When you take the emotion out of it and then you start talking about what basically equivalates into warrantless searches, that becomes a much, much larger issue than I believe belongs in the discussion of cannabis legalization in any state, because we have a constitution in this country.
Oh, I completely agree. Completely agree. I was just curious. I was looking into different states to see what they did as far as, the regulatory side of things. And when I saw that, because when we wrote the law last year, we did create, the compassion certificates, but the patients and caregivers were not subjected and would not be subjected to searches. And like I say, I just saw that in the New Mexico law, and I was wondering.
Yeah, the New Mexico law creates these facilities. Those aren't home grows that they're talking about there. Those are compassion centers, and it's completely different in the regulatory structure and in the law than a traditional home grow or anything that we're talking about here in West Virginia or that would be applicable.
Okay, got it. Well, I truly appreciate it. And, I would like, if I think that, Dr. Girdman and Lissa, if you could participate and come in and enter in some public comment at the full meeting on the 16th, I think that would be greatly appreciated. This conversation, I wish we were having it right now before the full board.
And one of the issues, hey, Rusty, just to jump in on that, one of the issues we always tend to have, at least recently with the full board, is trying to get enough time given all of the different people that are involved in that. And I think that's why, it was good that you're able to put this sort of a more in-depth presentation out here, and then hopefully can kind of summarize that to the full board. And if they can be available for some comment, I think that'd be terrific. But, I think we all have to kind of bear in mind that there tends to be a sort of a tougher time limitation on the full board. And I know, at least from my perspective of this work group, we want to hear all different sides. We heard from a doctor recently at one of our meetings that had major concerns over this area. We've heard from these folks that obviously think it's beneficial both for patients and for the program overall. And of course, we're charged as an advisory board with implementing a law that's already passed. And part of that is that we're supposed to look at, are there other ways to help with patient accessibility and affordability, but also understanding the program's got to be viable. And we're very early, even though, we're 5 years into this program in terms of the law being passed, We are just now getting this out into the stores. And so, I mean, there is going to have to be some time of seeing how that moves. But obviously we've got a legislative session coming up. And so, I mean, I think it's great to have this perspective and any alternative perspectives. If we've got perspectives that are not in agreement with this, we want to hear from all sides so we can make an informed decision. That's my view of it anyway. And I think it's great. I didn't mean to interrupt you, but I just thought might want to mention to them, if they can come to the full board meeting, it may be more limited in terms of to a public comment time, just given that, obviously with DHHR's involvement, they have a number of things going on. We have a number of doctors on the board and other professionals and people that are trying to juggle enough time to get that meeting in. So that's why, I know our work group has been willing to do these meetings in the evening and to go like we are now, where you're going, for a significant amount of time, because we want to hear about it, and then we can report in a little more in depth to the full board. So thanks.
Well, is anybody, anybody from the board, do you have any more questions for any of the guests?
Go ahead, Joe, if you have anything.
No, I mean, I just wondered whether or not there's going to be, comments. I don't know if there's folks on here that may have some other points of view that we need to hear before the meeting ends.
No, I was going to invite comment from anybody that's here, and we probably need to move to that because, I mean, we're already, it's 7:15 and we've got, I think it looks like 30 some people on the line. So if there's no other questions for the speakers right now, why don't we go ahead and move into if there's any public comment, and it can be comment anyway. I mean, what we're talking about this evening is home grow, really. I know it got touched on as to the concentrations and THC levels. That's something that's been brought up at the full board before. That's something that I believe our work group will be looking at. And I think we're going to need a more in-depth conversation on that and a separate subcommittee meeting where we can have points from all sides present at that. And we can make, some recommendations from the subcommittee and then ultimately to the full board on those issues. I really think that the concentration level, at least the way I had intended to come into this meeting, is for a different day. I understand it kind of dovetails some into this conversation. But if there's anybody here that's on the line that would like to speak or just has comments, I'd ask you to try to limit them to about a minute, given the time we have. I mean, I don't want to do a Jeopardy countdown thing, but if we get there, we will. So let's go ahead and move to that now. I think the way to Jason, last time, didn't we allow people to maybe put in the chat box that they wanted to comment and then we called on them?
Yeah, that's what I would suggest. If folks do want to make public comment, just type your name in the chat box and we'll call on you one by one. That'll keep things a little bit more organized. So again, just put your name in the chat box. Okay, it looks like first is Amanda Veziant.
Veziant.
Okay.
Just to touch a little more on the patients that really need this, we've got some homes that have multiple patients inside of them. So when you're talking one patient running up to $1,500, when we look at having households with multiple patients, that medicine's easily going to run into a few $1,000s that these patients do not have. On the other end of that, I have also talked to representatives from some of the companies that have invested in this state for medical cannabis. And they have actually said that if we do a home grow program, that they would be willing to offer patient education classes. And if allowed, they would be offering seedlings as well. So we could still keep some form of money in the program, even with a home grow option.
Thank you. It looks like next is Dr. Michael Mckenzie.
Hello, good evening. Can you hear me?
Yes, sir.
Okay, perfect. Hi, my name is Dr. Michael Mckenzie. I'm a board certified family physician. I currently practice in South Florida, where we've had a medical cannabis program since 2016 with the Passive Amendment 2. Home grow is definitely important because and for a lot of the patients with chronic conditions, yes, they cannot afford the high price of some of these medications. So home grow does give them the option to cultivate it themselves. And also, if they want to make their own cream, their own tinctures, themselves, that's perfectly okay. I know that this is meant to be for the home grow issue, but I did want to make a small comment about the this cap proposal. One thing that we have to understand when it comes to cannabis and medicine, okay, when you look at the two fundamental characteristics of the plant, number one, heterogeneity. There is no such single solitary thing called cannabis. It can represent any combination or ratio of cannabinoids, terpenes, and flavonoids, okay, with different delivery methods. Okay, second, pleiotropy. It has multiple potential uses. And also the use of cannabinoids is off-label. Okay, that's like the first slide of my slide presentation is off-label. So the heterogeneity and pleiotropy precludes us from treating it as a single agent. Those single entity molecular agents that myself and the other doctors in this forum have been trained on since medical school residency and fellowship. It is not a single agent, and we cannot look at it in terms of a percentage of THC. None of us experienced cannabis clinicians dose anybody based on a percentage of THC. We dose it based on milligrams intake, okay? So if somebody's needing 100 milligrams of THC, where somebody may only need 5, everybody's endocannabinoid system is different. Defects within the endocannabinoid systems are all different. So we cannot treat cannabis the same way we treat metformin, lisinopril, because metformin and lisinopril are single molecular agents, whereas cannabis is a combination of things. And you may need different strains to address different medical issues. Basically, in a long story short, whatever you guys need from us, we're willing to share. I sent you the link to my slide presentation, my a lecture that I gave, as well as resources for clinicians that everybody can partake in. So if whatever you guys need from us here in Florida, in terms of the mechanics of, running a program and things like that, hey, we'll be more than happy to engage with you guys and share whatever we have with you, okay? Because the doctors in West Virginia, obviously, they haven't been trained on cannabis therapeutics. So it's relatively new to them. And no doctor is going to incriminate himself by saying, yes, I've been recommending it for patients all along before we had a program. So, whatever you guys need in terms of, if you need, physician education resources or anything like that, you want Dr. Gerdeman or myself or whoever to come to talk to y'all in West Virginia, I'll gladly travel up there to talk with the doctors up there. We can do it via Zoom, however you like it. We're here to help.
Thank you, sir.
Doctor.
Next up is Aaron Borho. Aaron,
yes.
are you
Yeah, can you hear me?
Yes.
Hi, I'm a student at WVU who is involved with a group here called Students for Sensible Drug Policy, whose goal is to end the war on drugs through community engagement, harm reduction, education, and policy reform. But more pertinently, I know that you had mentioned the idea of doing home grows, and actually somebody in the chat right before I started to mention this mentioned the idea of collective grows. And I like the concept of that a lot because it would basically you could have community or regionally based growing communities, and it would give access to more patients in more areas and with cooperation with already knowledgeable growers, say people from the hemp industry or say out of state, better products. Now I think like perhaps a special form of licensure could be created for operations with like a lower buy-in rate proportional to the amount of actual patients that they'd be serving. And so that lower buy-in would be a lower cost starting materials because it can be costly to buy fertilizer and nutrients and air pots, and depending on if you're doing, you know, hydroponics or anything like that, that's, you know, those are all massive costs and also are not very easy for most people to set up and maintain. And so, you know, the community aspect of that, I guess, would allow already knowledgeable growers to help maintain that, and yeah, generally give better access to patients. It also cuts down, obviously, on the time investment of having to learn how to grow, and, you know, creates some sense of community interdependence. As I had mentioned, you know, hemp growers can already have kind of extensive training in relevant horticultural and agricultural techniques. And, you know, even in the case of, like, say, these were to be so successful that they would have excess product that could then be sold to state dispensaries and help mitigate the costs of whatever people would have to pay in to be a part of one of these co-ops. I also think that, yeah, again, the patient registry could create like a scaling cap for these license holders, insofar as, you know, how many plants, how much canopy space, all of that they would have at any one time. And even something like community concentrate processing. So like having these community hubs also be a place where if people wanted to say have some form of hash oil or Rick Simpson oil, or as Dr. Mckenzie had mentioned, salves, ointments, all of these different things, that there would be a place that's already knowledgeable about how to create them, and has the materials and equipment actually necessary to do so. That way you don't have, you know, people who are home growing who want to have some form of butane hash oil having to blast their own butane hash, because that can be extremely dangerous.
Aaron, I'm going to have to ask you to wrap up your comments, please.
Yeah, the last thing was it's something slightly separate as the concept of like DCMS. It's more a question. Kind of done, and in the case of like community growing, allowed them to test for the content of for potency, basically.
Thank you, Aaron. Next up is Tony, and I apologize, but I'm not going to attempt your last name. So Tony, are you there?
I am here. Thank you. Tony Dikiakio. I'm from Morgantown. I'm on the local board of health. And this is more of a question, and maybe after the meeting, if there's time, or people can reach out to me individually. One of the biggest concerns I have about home grow is, and people have made reference to this throughout the presentation, is the diversion potential. And I wondered what other states have done about that, particularly to vulnerable populations like adolescents or pregnant women, for example, how even with the commercial market and marijuana, there is not a lot of post-marketing, post-sale diversion control. And in West Virginia, we saw a lot of that with the opioid epidemic, how post-prescribing, post-dispensing, there was a lot of diversion. So I would really be interested in, if this is something that we pursue, how do we prevent it from getting into the hands of the wrong people, particularly since people made reference to people that are already growing and selling may use this as a tent of protection.
So I'll just give a quick answer for OMC. This is not part of the current law. So we have not devised a regulatory scheme surrounding that. Certainly if it were to pass, we would definitely look hard at diversion aspects. I'll turn it over to any board members that want to comment.
Well, it sounded like the question may have been directed to the folks that presented as well. So if they have anything that they want to say, you certainly jump in. I'll just, I mean, from an attorney perspective that has done a lot of different types of work all around the state. It's been said earlier in this meeting, there's plenty of illegal cannabis out there for folks that want to get it. Well, unfortunately, whether you're adolescents or, as you mentioned, somebody that's in a vulnerable state, it's on the streets. The difference is, of course, you don't know what's in it. It's a street drug, and it could have fentanyl in it or something else. You have no idea what's in the marijuana you're buying out of the street, versus at least with what's started here, we have a regulatory scheme seed to sale with what's happening now. And then of course the question would be if it goes to home grow, how do we get some kind of regulatory scheme in place to try to protect what's in it? And then to your point, after it's grown, is there something that can be done? Of course, you know, with divergence, you know, you can have that with a legal medical product. You can have it with these folks can go out on the street and try to buy street drugs, marijuana there. So, you know, I mean, that's always going to be a concern. I think that's something we always have to try to put as many regulations and things in place as possible to keep this safe. But at the end of the day, if people want to flout the law and break the law, they're going to do that. I mean, we've seen that in states across the country that have passed medical and recreational, even recreational cannabis, and there's still a black market for it. Does any of the other people that spoke today want to chime in, or other board members?
Yes, I'd like to chime in on that. When it comes to issues of diversion, okay, now we see diversion even in black market products. Now, the key is you want to address the issue of youth having access to diverted products. The key is if you want to get to the root of the situation, okay, first of all, let's ask, why would a teenager want to seek out illicit cannabis? A lot of times with these kids, they're self-treating. You know, the kids are not immune from psychiatric pathologies. So some of these kids may be having anxiety disorder or some other issue, are self-treating, and they're self-treating with black market products. So if you really want to get to the root of the situation, we need to also have the conversation about access, because we all know coverage insurance does not equate to access. So if these kids have access to proper mental health services, like for example, one thing that can be done, when you do your school physical, there should be a depression screen. We call it a PHQ-9 depression screen in every school physical to see, okay, is there an issue with this kid? So we can intervene early so that this kid does not feel the need to self-treat with street products. So part of the diversion plan would be to work on increasing mental health services access to these kids, especially if these kids have Medicaid. I can bet you dollars to donuts that they're not going to have very much access to psychiatric care if they have, let's say, West Virginia Medicaid's program. You know, and then they need to look at how much are you paying psychiatrists to see these kids. You know, if they have no access, they're going to go out into the street and self-treat. So if we can have something in place so that these kids can have access to mental health services, you can nip this in the bud at that level so that you don't have to worry about whether a kid's going to take part in the black market.
And I would just like to comment from a patient's aspect. You know, when I was going through aggressive chemotherapy, I went from living a very comfortable life to financially devastated in one cancer diagnosis. Had it not been for the generosity of friends and folks around me, I wouldn't have even had cannabis to get through chemotherapy. And if I were growing my own in that situation, the last thing I would have wanted to do would be to get rid of any of it. I needed all of it that I could get. So I really think that patients, you know, again, we've got to stop looking at this like patients are going to grow to sell, because that's just not the case. Patients, they need this medicine. And if somebody needs this medicine bad enough to, you know, painstakingly tend to a plant for 4 months, they're not, I just find it very hard to believe that their main goal is to get rid of that.
Mm-hmm.
Rusty, if I may also add, there's never been a reported overdose yet of marijuana. And Lord knows our state of West Virginia has suffered a huge opioid pandemic that has overdosed many of people. So again, we have more things and more issues to be concerned about than what the cannabis and what could happen with it.
Exactly. Exactly. Because you know, with the cannabis,
Folks, I need to cut you short here. We're already past our allotted time, and we have several more people. Rick Vaglianti.
Yes, I'll be brief. I was encouraged to hear Dr. Girdman say that there are no good randomized controlled studies about marijuana, particularly in chronic pain. And I also want to allay any fears that there's really no rush to judgment here. because there are FDA approved products which are reimbursed by insurance companies that contain THC that we use every day. And so that should make you feel better that there's no real urgency here to make a move on this without thoroughly considering all the possibilities. Thank you.
Next up, Jeremy Husted.
Can I just address briefly that I think I was misunderstood? I most definitely did not say that there are no good randomized clinical controlled trials for cannabis, including for the use of pain. There absolutely are. It's been well reviewed by the National Academies of Sciences and Medicine. I just said that most of there's much more clinical successes outside of clinical trials that therefore get called anecdotes, but it's not correct for me to quote me as saying that there is no gold standard randomized controlled clinical trials for cannabis. Thank you.
Thanks, Greg. Jeremy Husted.
Hi, so this is Dr. Jeremy Husted. So I'm a physician at WVU Medicine. I work in addiction psychiatry. So I unfortunately have to treat a lot of patients that struggle with these various things that we've talked about, whether it's PTSD or opioid use or cannabis use, or alcohol for that matter. I'm also the president of the Society of Addiction Medicine in state. So I feel like I have some expertise on this. Some concerns that I have with this discussion is it's been very one-sided in general. And if we're being honest, in science and medicine, the idea with it is to have open discussion and hear multiple viewpoints, not just to be bombarded with multiple stories from one side. For every anecdotal, and I will say anecdotal because that's what we have when one person says it, that's the nature of the term. For every anecdotal story that we have of it helping, we also have stories of it hurting people. And as much as we can march folks up that say that it helped their PTSD, I can also march patients up that have struggled with cannabis, that it's harmed them, that they were given false promises by various people looking to capitalize on people in pain. And it's very unfortunate to hear when those stories are not brought to attention and all we focus on is the purported benefits, which we realize that there are some, and I'm not completely opposed to everything that cannabis has to offer. What I am opposed to is not pursuing proper scientific argument. And I'm opposed to us going down a rabbit hole without actually considering the reasoning behind some of these other things, restrictions, for example. There's a reason that other states have not pushed forward with this. There's a reason why we only have 2 sites so far and we have not expanded it. There is no other medicine in the world that somebody makes at home on their own, administers to themselves and doses themselves. We've talked a lot about the benefits of marijuana. We did not talk about the increases in suicidality in younger people. We did not talk about worsening of PTSD. We did not talk about addiction, of which 10% of people at least that smoke cannabis are addicted to it severely, to the point that I'm seeing them in the hospital. Nobody has ever overdosed from marijuana, true. But guess what? States that have legalized marijuana and very much embraced it, rates have gone up of overdose. So it is not a replacement drug. It is along for the ride. So we need to balance these anecdotal reports with reality and hear the other side of the story as well. And I would appreciate everybody to consider too that some of the people reporting here have financial gain to be had by the introduction of more and more cannabis. I have no pharmaceutical affiliations. I just want to see patients not dying of their diseases, including many of which can be exacerbated and not helped by cannabis. So consider that, who you're hearing from, what their stake is in the game, and what they look to get out of it. The marijuana that has been, the cards that have been given out, they are generally not by physicians in this state that have been practicing. These are physicians that are coming in looking to make a profit. So I would just caution everybody and say, relax and think about this with a very clear mind and look what other states have done and the hurdles that they've had, including Colorado and California, and the things that addiction people like me have said before, because we've warned this years ago with opioids and we're largely ignored. So I'd encourage you to at least consider what people that treat addiction are saying, because it's a very real problem that we need to look into. I appreciate the time.
Thank you, sir.
Before we move on, Jason, I just want to address something there. Dr. Husted, thank you for being on here and listening to everything and speaking. I do want to address the idea of this one-sided presentation. Number one, I just want to make sure everybody understands what our role this evening is. So Mr. Williams has made a request of the full board to consider making a recommendation to the legislature from the advisory board that they change the law to allow for home grow. That's been brought up months and months ago by Rusty. In bringing that up, it got assigned to our subcommittee to consider various opinions from this. We have had speakers over prior subcommittee meetings that were clearly very much against the idea of home grow. People have spoken out about that. We have had, Rusty is here this evening making his presentation and chose to put these people up to explain why it is that he thinks it's beneficial. And so from a board, I just want to be clear, at least from my perspective as a board member and the chair of the subcommittee, I want to hear from every perspective, which is why I really appreciate Dr. Husted being on this meeting. I encourage you to
financial stay. I have zero financial.
Let's not talk over everybody here, but I hear what you're saying. What I'm trying to make sure everybody understands is we have a number of meetings here and we want to consider every perspective. And so that's why I appreciate Dr. Husted's comments. I appreciate the other doctors' comments earlier and appreciate Rusty's position on this. And we want to hear from everybody so we can make an informed decision about whether we make a recommendation. But something else that I think everyone needs to understand is our job as advisory board members is not to second guess what the legislature already did and the governor already signed into law. They've already passed medical cannabis. Our job is to look at that and determine, are there tweaks to that law that should be made in order to make it more safe, in order to make it more affordable, in order to help patient access, and to make sure that the program as a whole is viable. And so we're looking at all perspectives, and I appreciate all perspectives in this, but I really hope people don't feel this is some kind of one-sided debate. I understand the presentation here from Rusty tonight was certainly advocating for what it is that he's asking the legislature to do and change. But here again, we've heard other perspectives, and we ultimately are going to take this to the full board. There'll be a discussion there. And if Rusty makes the motion and puts that presentation out there, there'll be a vote by the full board as to whether we even recommend it. We won't decide this. This is a legislative decision. We have no rulemaking authority as an advisory board, and we can't change the law. We can only make recommendations, which is why, and we're all volunteers. I mean, the board is not paid in any way. We are volunteering our time to try to help this program get off the ground. And I know there's only 2 dispensaries open at this point, but there's more that are on the way under the current law. And that's something that we don't change, and we don't address whether that law is correct or not. Our job is to look at it and try to see, are there things that should be changed with it to help implement the program. If people want to undo the program, that's something they ought to take to the legislature, because we're not changing the law. That's a legislative decision. Our role, at least the way I view it, is that this program was passed by the legislature. It is the law of the state of West Virginia. And we're supposed to look at ways to try to address the concerns that are in the bill, to help patient access, to help affordability, and ultimately to make this program safe. But undoing the program is something, if people want that done, you need to go talk to someone else, because that's not our role.
Next up is Dan Brammer.
Yeah, how you doing this evening, guys? Really quickly, I'd like to take this back to the home grow situation. I don't know how many of you are farmers or that have backyard gardens or grow plants in your home. The average West Virginian will not be able to grow a plant to maturity inside anywhere. Growing in a greenhouse is completely different than growing outside. I work with a rehab group here in South Charleston, and what I do is I teach them to grow vegetables to supply both the rehab facility. They have a small restaurant, and I have a greenhouse, I have a hydro grow, and I have outside raised beds. And to grow in a greenhouse or to grow in your closet is nothing like putting a seed in the ground outside and letting Mother Nature take care of it. They are completely different. So your average West Virginian is not going to be able to. I mean, this is not going to impact the dispensaries, I don't believe at all. Like I say, most of the people here in the state don't farm anymore. Most of the people here in the state don't have a greenhouse. Have you ever tried to grow something in your closet? I mean, it's tough to do. Okay, watering schedules are different. The amount of water you put on the surface of the soil in a greenhouse can cause dampening, and your plants will dampen off. Okay, they will rot off right at the ground in a heartbeat. So the average person is not going to be able to impact the financial side of this at all, I don't believe. That's from a grower standpoint.
All right, thank you.
Sure.
And folks, I would ask you not to use the chat feature to argue back and forth. That's not why we're providing it. Let's see. I don't see anyone else that obviously wants to speak in the chat. Maybe Chris Yeager. Chris, do you want to speak?
Yes, sir, please.
Sure, go ahead.
Okay, good evening, everyone. My name is Chris Yeager. I'm a Marine Corps veteran. I've worked on this issue with many of these folks on tonight for several years. Just a brief backstory. We've worked in the legislature, to kind of get this program up running. I myself had taken a venture out to Colorado, stayed out there for several years, and really kind of just jumped into the industry out there. Their home grow provision is 12 plants per individual in each household. And I just wanted to say that, and I did grow out there at home as a home grower, but 12 plants, if you are growing for flower, like Dan had alluded to, you're going to be lucky if you're going to have enough flower on hand to last you until the next harvest. If you take that down to oil, you're really looking at cutting that supply down drastically. And just to add to that, when you have different cultivars or varieties, you with a limited plant count, you're probably not going to be able to tap into the strains that are going to be beneficial for you throughout the day. There's going to be sativas and indicas. Those are going to grow differently. They're going to have different harvest times. So it just creates a lot of logistics. And alluding back to what I'm sorry I missed the name, but the lady that was commenting on diversion earlier, I just don't think that you will have enough. You'll be able to grow enough, to be able to divert it. And like Rusty had alluded to, he had mentioned, that medicine, barely being enough for him to be able to make it from one, application to the next. So I guess with that being said, tying this all back together, as a grower out there and growing home grow, I looked for concentrates. There were edible options that I wasn't able to partake at home. And so, I won't say that the home grow really stifled me as a customer in the dispensary setting. It just allowed me to grow some strains that I identified that work well for me. And then I was able to accompany that with individual strains that I didn't have access through the dispensaries. So I hope that maybe gives a little bit of a different insight to accessibility. I think it's just going to help patients open it up in that facet. And then also, I'm not going to get too deep on the rabbit hole with addiction, but I've lost 2 family members to opiates. And when we're talking about, a regulatory, position on home grow and things of that nature, I think we've got our hands full with opiate related problems in the state and overdoses. And if we're talking about, truly caring about patients' lives, again, what they've alluded to earlier, there's not been any patients that have perished because of cannabis consumption. We can't say the same thing for prescription drugs. So I really hope that as we move forward, that the board looks at this as an opportunity to expand access and really understand it and not go in and try to over-regulate it. I think I'll touch on this and I'll leave it alone. The arbitrary 10% THC level, I think it's going to make it extremely complicated for growers to be able to hit that mark. And if we do, how are we going to regulate it? Are we going to go in and subject these folks to testing measures? I think it's just an overreach in my opinion. So I appreciate you guys giving me a couple minutes to speak this evening. Thank you so much.
All right, Jesse, I think we got everybody there. As we wrap up, I would ask that the board members make it clear on if they're making an official recommendation to the larger board or not tonight.
So here's what I'd say on that. First, thanks to all the people for the comments. I mean, whether you're on one side of the issue, the other side, or just want to be heard on what it is, it's important that we have this public feedback. And so I really appreciate people taking time out of their schedules to sit here for 2 hours on this meeting and listen to these things. It's important for our state. It's important for patients, and it's important for everyone here to try to get this out in an effective way. A major concern that I have, and that why I think it's important that we look at home grow is that I don't want to see cancer patients out on the street buying drugs that are laced with God knows what. And I think that's something that's a real concern when you get out and you start buying street drugs. And so if they can't afford to buy the things that are in the dispensaries, this may well be another viable way to handle it. Now, another end of that is that we are only at 2 dispensaries in the state. It is very early in seeing this product roll out and patients begin to get things from the dispensaries. So I have concerns in that regard too. And so what I would suggest to the subcommittee at this point is that as opposed to taking a vote tonight, that Rusty make his full presentation to the board and that we consider it there. I have concerns about making a recommendation right now when we only have 2 dispensaries open in this state, and we don't know what the ultimate effects overall on the industry are going to be and on patient access. Having said that, I do think this is important, and I think we need to get it to the full board. So that's my thought, is to let Rusty make his formal presentation to the full board at this point, and that we agree as a subcommittee that Rusty be able to do that. I don't know that we need to take a formal vote saying whether we as a subcommittee are recommending it or not, but I don't know what the other board members think.
I agree with that assessment. To be honest with you, after the last meeting of the full board, I'm kind of leery to put it up for a full vote because I've made a motion for the board to just take up the issue of reciprocity. We're still months away from dispensaries being open. We're months away from patients having access, and we've got patients living in.
Also written by the hand of God that altered the options.
That if we would have allowed reciprocity, they could go to Maryland, they could go to Pennsylvania, they could go to Ohio and medicate legally. I made a motion for the board to just look at the issue of reciprocity, and I couldn't get a second on the motion. So I don't feel real warm and fuzzy about trying to put this up for the full board when, in my view, I don't think that they really are concerned with patient access at this point. I think they're far more concerned with what the industry is doing rather than what patients are. So I'm more than willing to do a presentation for the full board. I think it needs to happen, but I also feel like we need to bring folks like Lissa, who's experienced the regulatory side of this industry in states where home grow is working. If we could bring her in to address these issues with the board, I think that would be beneficial. But I'm extremely frustrated with the pace at which things are moving, and it really just it sent a powerful message to patients at that last meeting when we could not even get the board to look at reciprocity. That's a problem. So I don't think we're ready for a vote right now as much as I would like to. So I'm more than willing to make the presentation, but I do think we need some folks who have experienced the regulatory side of things to come in and address the board.
So again, for clarification, is the action you guys want to take basically for me to put Rusty's presentation on the full board agenda?
That's my motion, is that Rusty be allowed to make a formal presentation to the full board. And I think we continue the discussion from there.
I would just add that, I think that the people that don't completely agree, and Rusty, I don't agree. I think you've had plenty of opportunities with the subcommittee to present, how you feel about it, and tonight, that's been pretty much focused on where you're coming from. So, I think we need to have it in front of the full board, but I think that we need to have the ability for people who have different points of view to be able to speak also, and not be put down when we're not putting you down when you speak. The chat box, was a little bit disturbing to me this evening.
I'm not trying to put any. I just want
just making my comment, Rusty. I don't.
And I agree. I mean, we definitely want to hear from all sides, but I do think that the conversation has been one-sided up until now. All of the folks that have been invited to present at these meetings have been anti, and I mean, to say that isn't true is just, I don't know where you're coming from. But again,
I don't know where you're coming from with that. That's just not true.
I'm coming from a place where I have talked with more patients than I could possibly count since this law was signed into, law, that are dead, that did not have legal, safe access to a flower that could have given them some relief. So if I come across as passionate, I'm not going to apologize for that. Like I say, these patients are relying on me. Again, I am not the business advocate. I am not the cannabis company advocate. I am not the dispensary advocate. I'm here to represent patients. And when you're coming into these conversations with not just hundreds and hundreds of patient stories, but you're also coming into this conversation with patient stories who they're no longer alive to come and share their stories. For me, this is an issue that the legislature should have enacted home grow from Jump Street. Had they done that, these people who are dead would have had access. We're dragging our feet, and there's no need to. When we're talking about putting the brakes on home grow to let the industry go and get up and running, you have to take into account that the legislature will be over, the session will end, I believe, in March this year. So from what I'm hearing from dispensary owners and permit holders, we should have our industry running pretty well by March. So if the legislature decides to enact a home grow provision to this law in March, and patients can finally grow, you're still looking at 3 to 4 months before those patients will have access to the medicine that they're growing. The timeline, I just think that we're scared of things that we shouldn't be scared of. And again, I apologize if you've taken it to where I was putting someone down, because I truly don't want it to be that way. I appreciate everyone's input on this conversation, but again, when it comes to representing patients, that is what I'm here to do, and I will do it as loudly as possible.
All right, folks, just to keep us on track, what I'm going to do is put Rusty on the full board meeting agenda for a home grow presentation. Rusty, as the person that has to facilitate these meetings, though, I would ask that you be very cognizant of time constraints, especially with the heavy physician involvement in that meeting. I don't think it would go well if we ran over. People would have to drop off. If you do want to utilize speakers, please let me know ahead of time so we can plan that out.
Yeah, I think you're going to have to limit the time on the speakers. I mean, there's just no way with that full board meeting to go as in depth as this presentation was. But I think this presentation is important, and the conversation is important. And hopefully we can focus on that and having, an intelligent discussion about how do we help people? How do we help enact this law? How do we move forward with that? And we can do that at the board meeting and go from there. So that's my recommendation at this point, is exactly what Jason just said.
All right. So one more question for the members from my end, just to be cognizant of all the proposed recommendations. Does this subgroup have any appetite to attempt to meet again before the soon upcoming full board meeting to discuss anything else?
I don't think that it's practical. I mean, our board meeting is it middle of the month? Is it on the 16th?
Yeah, I think so.
It's the middle of the month. I don't think it's practical to try to schedule another meeting in the next 2 weeks. I really think we need to address the other issues that we kind of got touched on here, such as THC content and reciprocity. And those are things that we need to take up and we ought to address, but I don't think those can be addressed between now and the next board meeting. And my suggestion is that we take one of those up at our next subcommittee meeting and then go from there. And we can schedule another subcommittee meeting following the full board meeting. And there's some questions in the chat I saw earlier about, will there be more meetings by Zoom? I believe that the full board meeting again will be by Zoom, right, Jason?
Yeah, that's right. Jesse, we're making every effort to at least have a split format, both live and Zoom. But just the way things continue to go with the pandemic, BPH can't support that at this time.
So it'll be Zoom for the full board meeting. If the public needs access, just reach out to the Office of Medical Cannabis. They can explain how to do that. I mean, from my perspective, we want as much public input as possible. I mean, we want this to be open and we want people to be commenting as they are tonight. And if anyone thinks it was one-sided, tell people about the meetings that are on the other side. They can come give us their opinions too. We want to hear from everybody because we want to see this program continue to move forward. So any information we can get from the public or other people that are in the industry or doctors or have concerns, I know I'm happy to hear it. So I hope you can attend on the 16th, listen then, and our next subcommittee meeting, if it's continuing with the issues that we're having with the pandemic, it'll likely be by Zoom. I'm hopeful too we can get back to where we can have this stuff in person. But obviously here we have to find a facility and have this many number of people. And then sometimes it's difficult in our state for folks, if you're in the Eastern Panhandle and you're 5 hours from Charleston, where do we meet? Do we meet there? Do we meet here? So there's issues with that too. So the Zoom, the hybrid idea helps some, I think, on that front.
Yeah, we've already identified a good facility at the Capitol complex that already has the equipment for that. And it's just, again, with the new variants and just the overall pandemic situation, we can't support it at this time.
Well, I just want to, before we shut this down, I do want to thank, Jason and the Office of Medical Cannabis and Jesse and Mr. Deegan for participating in these discussions. And I would like to thank Lissa and Dr. Gerdman and Becky for sharing the information and your stories. Like Jesse said, these conversations are crucial and we need to hear from everybody. So, I really appreciate everybody for taking the time to, to sit here for 2 hours tonight and join this discussion. So thank you all.
Thank you.
All right. I think we're done then, right? Nobody has anything else? All right. Thank you, everybody. Thanks for attending. Please come on the 16th or come watch, participate. Thank you.